All right, everybody have a good lunch? So my job is to make sure you don't fall asleep, I guess, now that you have full bellies. So I'll do my best. So I'm going to switch gears a little bit to start from this morning. This morning was more about distance running, and now I'm going to move into sprinting and hamstring strain-related injuries. We'll move back to distance running toward the end, but I want to start off with some sprinting data. So I'm going to talk on two particular injuries, both related to the hamstring, but really, in many ways, very different in how we need to manage them. I will admit that over the years, I absolutely failed at managing proximal hamstring tendinopathies very well. I did not do very well. It took a long time to get a little bit of improvement. But I think we've kind of stumbled on some ideas, and largely influenced by Jill Cook, Dr. Jill Cook, who I notice is one of your speakers at next year's sports physio meeting. She's fantastic. If you have a chance to hear her speak, and you do next year, I certainly encourage you to attend. But then we also did a large body of work related to acute hamstring strain injuries. So we received funding from a number of different sources to understand why is it that hamstring strain injuries, those who sustain a hamstring strain injury, about 30% will re-injure in the few months back. And those numbers are quite staggering when we start to think of it. And that's after they've undergone care, yet a third were re-injuring themselves. It suggests that we didn't understand the mechanism well, we didn't understand the rehabilitation process very well, and we may not have understood what the mechanisms of injury really related to. So that kind of started us out with ideas such as this, which is really when we're seeing hamstring strain injuries and trying to understand what caused the injury, many times we're left with videos like is shown on the top right. You see this person who does the classic, the clinically valid hamstring sign, right? Where they grab the back of their thigh, you know that they've torn their hamstring. It's kind of one of those typical mechanisms, right? But to understand what caused it and when in the gait cycle was actually a long-term debate. Many argued that it was occurring when the foot hit the ground. Just as curiosity, show of hands, who believe it's when the foot hits the ground that the injury occurs? How many believe it's during swing phase that the injury occurs? Good, I'm glad. We've got, I won't have to do much convincing then to show you. So that's where we led. It was our first topic, our first task was to show when the biomechanical loads on the hamstrings were at their greatest or were most related to what we'd suspect would occur for an injury. And so that was some of our initial studies were related to trying to understand what this looked like. And so as I mentioned on the bottom, you can see two images showing when the foot hits the ground and the loads on the hamstring versus when the runner is during swing phase and the types of loads on the hamstrings. Now, many of us believe that because there's ground reaction forces, that means the loads on the muscle, the loads on the hamstring in particular, are automatically greater. And that is true when you're at slower speeds. When you're at 60% of your maximum speed or slower, the loads on the hamstrings are greater during stance phase. But once you start exceeding 60%, 70%, 80% maximum sprint speed, the forces on the hamstring are actually greatest during swing phase because of the inertial loads that are associated with it. But not only are the forces the greatest, one of the key issues is the fact that the negative work, this area we refer to as negative work, which is really an indication of the amount of eccentric demand on the muscle, occurs during swing phase. There is no eccentric work on the muscle during stance phase. And so if we tie that into our animal model data and our understanding of mechanisms of injury for muscle tendon injury, negative work, large forces led us to believe that it was really primarily a swing phase injury. And then we had the good fortune of having somebody run on a treadmill, not in my lab, mind you, but run on a treadmill taking part in a study. And they jumped off the treadmill before they were supposed to. And they gave us what is known, as you now know, as the classic hamstring sign. He tore his hamstring while he was taking part in a study. Awful for him, but fantastic. Fantastic for us. This gave us really good insight as to what may have linked to the injury. We had several strides of him running where he was completely injury-free. And we had, at one point when we knew he was injured, is when his arm started to reach for the bar. We knew he was injured at that point. Before that, we had to speculate when the injury happened. And so we did a variety of different biomechanical analyses and stats interpretation of as to what the predictability was when the injury would happen. And lo and behold, it lined up very nicely with terminal swing. We'd identified a region of 100 to 200 milliseconds that corresponded with terminal swing. Now, a couple of years after we published this case, a group out of Australia also had the good fortune of injuring a subject, and also identified swing phase as being the most likely candidate of when the injury happened. So now we've got biomechanical data, we've got two objective case data that both turn to swing phase as being this primary mechanism for high-speed running-related hamstring strain injuries. So we then started a series of studies looking at individuals who had sustained a hamstring injury in the past, and what did their recovery look like. And essentially what we found, these were individuals who were 1 year, 2 years, 3 years post-injury, back to sport, they no longer had any symptoms related to their injury, but they showed a sustained amount of atrophy of the biceps femoris long head. I should note that the biceps femoris is the most commonly injured hamstring muscle during high-speed running. So about 10% atrophy was present. But what we also identified was that the short head actually hypertrophied in these same subjects. So when you test knee flexion strength, like you would in a standard clinic manner, the knee flexion strength would test normal. They would test fine because the short head was making up for the long head deficit. And so it's really important to add some level of hip extension assessment as well, or a way to see if you can tease out that long head issue. In addition, what we noted, and again, this isn't that unique, but we found that the amount of scar tissue is actually quite substantial. They generally, the tendon, again, most on standard MR scans, T2 scans, that you cannot differentiate tendon from scar. Both shows up as hypointense regions. So you see that thick black area that is a combination of tendon and scar on the previously injured side, compared to the non-injured side, and it's substantially more. In fact, there's roughly about a doubling in size that we found near that tendon from the prior injury. And this was consistent across all of the, we've now collected data, MR data on over 70 hamstring injured athletes, and they all show this level of scar tissue rather. But what was interesting is that their running mechanics, there was no asymmetries. Even though they had this atrophy and they had this increased tendon and scar tissue development, which would suggest more stiffness in the tendinous tissue, the actual joint kinematic showed no asymmetry. Their muscle was going through normal range of motion. It was being lengthened the same way. But again, you've got altered tissue properties. So our thought was, if we did some MR imaging, dynamic MR imaging, could we look at local strains? And what we identified was that under eccentric loading, we did this in a magnet, we did an eccentric load from 0 to 30 degrees of knee flexion. It showed the red area is the higher strained area. This was the region where the injury occurred, right along that muscle tendon area. The hotter colors, the red colors, indicate greater strains relative to the non-injured side. And so even though they're not showing any visual, objective joint kinematic data, there's clearly something internal that is happening that's altered the muscle tendon dynamics. We then started following individuals on a longitudinal basis from the point of injury to the point of when they're cleared to return to play. And I think one of the most interesting things that we identified was the amount of injury that still remained despite passing all of our standard clinical return to play tests. So these individuals were cleared to go back to sport. They had zero pain upon palpation. They were able to sprint without any apprehension, full range of motion, normal strength for all of our testing, and yet they showed a 20% of the muscle still showed signs of edema or fluid formation. So in other words, still muscle injury, still recovering muscle, which makes sense given that the highest rate of re-injuries in those first couple weeks back to sport after the injury. When we looked at him again 6 months later, the edema is fully resolved. In fact, we speculate the edema resolves within the first 2 to 4 weeks back. But of course, the scar tissue then is fully formed and clear and evident through that time point. There were strength deficits when we did more rigorous testing. So even though our clinic assessment showed there was no strength loss when we did isokinetic testing, especially at end range, when the muscle is at its longer length, we showed sustained deficits in strength toward that 30 degree, 20 degree, 15 degree of knee flexion angle. So it's not that necessarily that the muscle has weakness in terms of peak torque, but it does have weakness in terms of torque production at longer muscle lengths. So that becomes a very targeted area that we want to make sure we address during our rehab time. And so that led us to develop our rehab program that we published a handful of years now. And we broke it into 3 different phases: phase 1, phase 2, and phase 3, and each has its own goals associated with it. So phase 1 is right away. As soon as the injury happens, we do not want the individual resting. In other words, doing nothing at all. We want them doing something pretty quickly. But we're going to be very controlled about what we let them do. We are not doing any stretching. We are not doing any end range of motion activity. We're doing very controlled loading within a confined range of motion. Because our goal here at this point in time is to protect the scar, let it develop, but protect it. Don't let it go too crazy. Let it develop it as it needs to and minimize the atrophy. So we do a lot of exercises such as prone bridge, something very simple. But again, imagine this after a day or two, after an acute hamstring strain, this can be moderately painful. But we're keeping it protected. We're only allowing a little bit of load on the muscle during that time point, and in a very protected range. The hip is at 0. The knee is flexed. So we're keeping it in a controlled position where we're not putting a lot of strain on the injury site. Our criteria for progression then is they have to be able to walk with a normal stride without pain, very low speed jogging without pain, and sub-maximum resistance pain-free isometrics only at mid-range. We then move into phase 2, which is really at the point where we can start to make things a little more dynamic, but our goal is still, again, is to avoid that end range. We do not want to do heavy load at end range. So we keep them, we're moving toward end range, but we're not going there right away. So we'll do exercises such as side-to-side shuffling, but front to back, just getting that little bit of hip flexion as they're going through that maneuver, as they're going through that motion. Adding a little where we started before, now walking out. Now, I would not have him go that far right away, but he would work that way over a week or 10 days. Start doing windmills again, not full range right away. They would progress to this over a series of several days, maybe even a week or so, but adding that level of load into it. Similar with the lunge walk, this would be a reduced range of motion initially, gradually opening it up to full range. And then once they have a 5 out of 5 strength at mid-range, as well as pain-free forward and backward jogging at moderate intensity, they're ready to go on to phase 3. And phase 3 basically is let's do whatever we have to do to get them as strong as possible. So now, there's no real constraints or barriers to what we want to do. We want to take them full range. We want to push them as hard as we can. We want to try to replicate their sport as close as possible before we clear them to get back on the field. So starting adding more fast movements, again, trying to add that inertial load piece to the exercises, A skips and B skips. This is bordering on moonwalking instead of a B skip, but it's close enough. You can never find a good graduate student nowadays to demonstrate exercises very well. Or we can do a supine one-leg chair bridge. Similar, again, putting them up into that position, getting more toward that end range, working on the extension from the hip as while the knee remains in a flexed position. Now we're starting to add in some of the Nordic curl work. Certainly not a phase 1 or a phase 2 exercise, but you can start to bring it in more toward phase 3, especially if you modify it and guard it like so, using a Physioball to constrain the range of motion. And then we can do some inertial loading, simulating swing phase with a tubing around the foot, adding that extra overload by pulling on the tubing to add that eccentric demand. So again, at phase 3, at this point, the full strength without pain is our goal. They need to be able to do at least 5 maximum effort repetitions at mid-range, as well as at 15 degrees of knee flexion. So it's not just mid-range we're testing 15 as well. If you have isokinetics, you can be a little more strict on what your criteria are. And then full range of motion. Now, I should clarify, our goal at phase 3 is they have to have full range of motion. We never stretch them at any point during this recovery process. The range of motion comes back with the exercises that we do. There is no passive stretching. There is no pushing them into the eccentric load, and the exercises themselves take them to end range without having to add that level of passive stretch to it. Okay. Switching gears now a little bit, moving into hamstring. Oh, I should actually add a follow-up point to it. So when we've tested this approach through 2 different RCTs, our rate of re-injury has now dropped to less than 7% on all of our athletes. So we've taken that 30%, dropped it down to 7% when we follow this approach. Our proximal hamstring tendinopathy then is a little bit different. You know, this is one, again, where we're dealing with much more of a true tendinopathy, so I would not want to treat it the same way. And that's where I think we went wrong, or I personally went wrong for a number of years, is I was treating it much like I would an Achilles tendinopathy, a non-insertional tendinopathy. I was doing a lot of eccentrics to it. And I realized that was the wrong thing to do right away. Because of the way the hamstring and the conjoint tendon attaches to the ischial tuberosity, you have a lot of wrapping. That tendon has to wrap around the bone, so you don't just have a tensile load that you're dealing with, you have a lot of compression that's occurring between the tendon and the ischial tuberosity, a lot of shearing. And so because of that, and again, this is largely influenced by Jill Cook's work, we've modified at least our initial approaches to how we go at it. So our first area in terms of pain management really is to utilize isometric loading to the tendon at that point in time. And we put them, like the picture shows on the bottom left, at 0 degrees of hip flexion. So there is very little tendon wrapping at that position. The more you flex the hip, the more you wrap the tendon, the more compressive load you have, the greater the resulting pain and the re-aggravation of the symptoms can occur. When we put them in this neutral position and do near maximum held positions, 30 to 60 seconds, 3 to 5 repetitions, 1 to 3 sets, we've had a nice reduction in their pain, and we're able to progress them much faster. In as little as 2 to 3 days, they're improving quite a bit. We can see a 20 to 30% pain reduction. And then we move them on. And once they are able to do it at 0 degrees, we move them to 20 degrees of hip flexion and repeat isometrics in that way. And then we continue to progress until they get closer to 30 to 40 degrees. Once they get to that point, then we can start to open them up to other exercises. At the same time, we want to modify their activities. We don't want to stop them from being active, but we want to modify what they do. So, for example, with running, the key thing we're concerned about is uphill running. That's an aggravating factor. There is no uphill running in my tendinopathy patients, or hamstring tendinopathy. They're not allowed to. Similarly, they're not allowed to run fast. Hip flexion increases with speed. I don't want that to happen. I want to make sure they're not overstriding. And again, when we think about that level of compression and hip flexion, I want to make sure that anterior pelvic tilt is not excessive. So I'm going to show you this example of a picture. This is an individual running on the treadmill. And as she's running, I've asked her to contract her core muscles, her transverse abdominis in particular. It's kind of imagining doing an abdominal drawing in maneuver. Not aggressively, only 10, 20%. I want you to see if you can tell me when she's recruiting it and when she's not. So right now, it's shut off. Now she's turning it on. Sorry, now it's off, rather. Now she's turning it on. Now it's off again. And now she's turning it back on. And so the difference in her pelvic position at the same point in the gait cycle when the contraction is on versus off, you can see a dramatic difference in the amount of anterior pelvic tilt. When we looked at the ground reaction forces that are associated with this and other loads, this has quite an effect even at the ground reaction level. The loading rate changes, braking impulse changes. So it has a nice effect, but in particular related to proximal hamstring tendinopathy, it helps to reduce that compression. And so we can certainly add in some more exercises related to an abdominal drawing in type maneuver where you're initiating it, doing a bridging, heel to toe, single leg raises, a variety. There's various ways to elicit this. We can do ultrasound imaging, and we do that many times to help bring out that biofeedback of the muscles to show that they're recruiting it or they're not, to teach that technique. Once we've got those areas addressed where we've modified their load and possibly modified their gait, and their pain is reduced with the use of isometrics, we continue the isometrics, but now we start adding more of our traditional eccentric training to it, taking them through that range of motion, but always being careful not to exceed their level of tolerance when it comes to minimize that amount of tendon wrapping. So we may do exercises like so on a Physioball, pulling them up 2 legs forward and then progress them eventually toward a 1-leg maneuver of this exercise. A repeat of the same exercise you showed before. This can be one again. Step 1 exercise is safe because the hip is in 0 degrees. If they flex their hip at all, that's a problem. They're not allowed to do this exercise. But as long as their hip is maintained in 0 and they don't flex too much forward, this is an okay exercise to do very early on with these individuals. Again, as we're able to progress the range of motion, we can start doing many of the old exercises that we did before. So you'll see a lot of overlap between how we treat the acute hamstring injury and the tendinopathy, but the real key difference here is that how we treat it early on. We utilize isometrics. We do not go directly to this level of load. Tipping forward, holding this position, again, once their pain is at a level where they can tolerate it. We then progressed into more plyometric type exercises where we're dealing with more of the inertial loading. For example, with resisted terminal swing, keeping that hip in a flexed posture throughout, adding that inertial overload consistent with what you'd see with distance running and eventual sprinting or speed work. Adding our A skip and our moonwalks back into, our B skips, not our moonwalks, back into it. Can be another strategy again to facilitate that level of load on it. See, I told you, he's moonwalking. Forward to backward acceleration is the same way to keep it rolling. So again, I think one of the key issues in terms of treating hamstring injuries is make sure, number one, that you've got a clear mechanism to indicate a strain injury versus a tendinopathy. And when you're dealing with a strain injury, realize that when they clear your return to sport criteria, there's still a level of injury that's present that we need to be respectful of and make sure we don't push them back too far. With proximal hamstring tendinopathies, the biggest advantage that we've had in recent years is the use of isometrics in that first week or two. That has greatly allowed us to facilitate and return people back to sport at a much more reasonable time frame. Thank you.